in educational status, does he or she stand a chance against the doctor? No. And where is the accountability of these providers going to be? It is going through the channel of a doctor reporting to a chief medical officer in the district level, and then reporting on to health directorate at the state capital level, and then reporting onwards to the health. So this channel of accountability, where is the accountability of the provider to the citizen? And have we, in these 10 years or in the last 50 years, have we been able to fix this accountability at all? Without fixing this accountability, can you imagine a situation where you say that just by pouring more money, things will work? I have a reasonably strong doubts that we will be able to do so. And I think that is the question which needs to be addressed. If at all that spending, additional spending is to be effective, we need to solve this problem. And without solving this problem, it would, to my mind, it will be somewhat incorrect to prescribe more and more funding to this sector. The second point was made. The point was made that the share of government spending on social sectors has remained stagnant over a period of time. Defense spending is high, and therefore, the government is not doing enough for the central spending. What was missed out was post 14th Finance Commission. So you had 100 rupees of total tax revenue. So you will not be able to spend more than that 100. Earlier, you used to give 32 rupees to the states as a whole. Now you have increased that from 32 to 42. And this was untied resource at the level of the state governments. They could use it for education, they could use it for health, they could use it for agriculture, they could use it for bijli, sadak, pani, whatever. Obviously, if you shared a higher proportion of your revenues with the state governments, what will be left with you will be a lower proportion. So now, if you are remaining stable for a lower proportion, the right question to ask is not whether you are 3.2% of that 68% or whether you are 3.2% of the remaining 58%. The right question to ask is whether as a total on the social sectors, you are doing better than or worse than what you were doing in pre-Finance Commission or 2012-13 days. And I have looked at this data very carefully. I am happy to share that. The share of and in fact, we were worried that the states may divert more of their money into hard physical infrastructure rather than on social infrastructure. Contrary to our expectations, we found out that except one or two states where there were some anomalies, as a percentage of GDP as well as a percentage of total budgetary expenditure, the expenses on social sector have gone up invariably across 32 states except 1, 2 or 3 where there was a problem in horizontal sharing of the formula of the Finance Commission. 3 states lost out, so they are actually getting less than what they were getting in the 13th Finance Commission award period. So to say that the spending on social sectors is coming down is not correct. In fact, the reverse is correct because the states are actually putting in more money because it is the constitutional response. And most of these subjects, please remember, is the constitutional responsibility of the states rather than of the center. Another point was made. Oh, social insurance has not made any impact. Well, so look at what we spent on social insurance and what we spent on NHM by contrast. The RSBY expenditure of when I tracked, maybe now it is 1500 crore, when I tracked it was close to about 1000 crores per annum. And the population which is touched was about 6 to 7% of the total population, but that is the total coverage. If you include other insurance schemes, Arogyashri, Kalangar scheme or Chief Minister's insurance scheme now in Tamil Nadu, add all that, the total spend would not be more than 1,000, 1,500, 2,000 crores. On the other hand, only the central share on NHM is close to about 20,000 crores. Now, is it fair to say that because the out of pocket was not being able to control by this small meager means, that is why the social insurance is not a success or is a failure? Again, I think we need to have a perspective. Unless we significantly invest or create that kind of an investment where a large segment of population is covered, only then we will be able to make. I can only say from anecdotal evidence. I was Secretary to Chief Minister in the government of Uttar Pradesh. Every single day I would come across distressed patients coming saying that, look, we are unable to afford care in Tata Memorial Hospital, please do something. And we used to regularly dispense from the Chief Minister's discretionary fund to help those families who were in distress. The secondary and tertiary level costs are going up, but in the manner which they are going up is causing immense distress to the families, and therefore there is a need for financial risk protection. Either you say that the government hospitals will do this insurance function, but if your share in the total service provision is only to the level of 30% in some states, and in some states it is higher, of course, how do you expand your public sector? Can you think of what a system which is delivering 30% of the overall share, can you expand them in the, let's say, 5 years, 7 years, 10 years to cover 80%? In fact, if you look at when we became independent, the government share of provisioning was almost 80%. It is now reversed. Now, whatever happened over the period of time, we can't undo whatever has been done, but as a realist, one would have to now understand that if 70% of the service delivery is happening outside the government sector, you need to find ways and means to engage them to subserve the public health goals. And that, I think, and therefore the critical challenge now before us is to really find out how we can use that resource which is available to us to subserve the public sector goals. So the fourth part which I wanted to say is that, and this on this I totally agree with my co-panelists on this or co-speakers, is that one of the things which has hampered India's health system is our obsession with the curative health side and our neglect of the preventive health side. So we, after 47, we actually systematically, most of the states systematically destroyed their public health cadres which the British had created, and we went more and more into specialized and curative care, which is a costlier system and which doesn't impact population as a whole in a much large, in a manner that it should. And the fact that we have to carry Swachhta Abhiyan after 70 years of the independence is something which says a lot about our focus on the preventive health side. Even today in UP, about 50% of your children, over 50% of the children are not fully immunized. And then you are talking about, putting in more money into the system. More money may not be the answer. Do I end? Okay, so let me just say 2 points and then I will end. In terms of, an issue was raised as to whether the pricing control of the essential drugs will lead to the best outcomes. If the logic of essentiality is an argument for pricing control, then we should have pricing control on water, then we should have pricing control on salt, we should have pricing control on every food item. I mean, the point is making drugs available to the public at the lowest cost or at an affordable cost. And Dr. Shiva in her presentation pointed out that if you organize a bulk purchase of medicines, you could, and is available in your public sector facilities, that would in a large way act as a check on the private sector pricing. The second part which you also need to consider is, suppose, think about an anti-snake serum or anti-venom serum, whatever. Think about, if it's an essential medicine, you will require it. What is the incentive for my druggist, my retailer, my hospitals to store that, if they are not able to make some profit out of it? Would you rather lose your life because those people are not storing the drugs because there are no incentive, or would you rather that even if they earn a little bit of money on that, let them store it because I would need it at the time when I need it? The third point to be considered, think about something as, suppose you are talking about anti-cholesterol or anti-hypertensive tablets. Let us say, I don't know on this particular issue, but let us say there are 15 manufacturers manufacturing it in a competitive manner. Do you really think a price control is needed? And the price controls many times, look at the kind of the manner in which the price is controlled. So you create a regulatory mechanism and look at how they function. So they say that they will follow a price cap. So somebody fixes 20% below that cap. Next year, let's say the price increases by 3%. This guy says, I am below the cap, I can increase by 5% because even after I increase 5%, I still remain below that cap. No, you can only increase 3%. You can only increase in once in a year. You can't increase next time. I mean, what kind of regulatory mechanism are we planning to put in place? So my point is, regulation is all very well, but we also need to understand the state capacity for regulation, whether regulation really turns out to be harmful or beneficial. Many times, you remember a situation prior to 1991 where we had regulation on the prices of steel, on vehicles, on every single thing. And what did it result in? So my point is not that I'm arguing against price controls, but all I'm arguing is it the only instrument to make affordable medicines available to the citizens? If it is not the only medicines, do we then, because of ideological reasons, say that, no, we're not even going to consider other options? That's all I am trying to say. And lastly, I just wanted to say that at Niti Aayog, we have come out with the 3-year action agenda. I would, and on health, nutrition, and other issues, I would urge you to go through these. And also, we are now requesting and also urging the states and the district hospitals to be more outcome focused. We have bought on a series of index. These books are also available on the idea being that if public resources are being spent on health, the outcomes, the focus should be on outcomes, and focus should not only merely be, yes, we have created this many PHCs, we have created these many frontline workers. It should also be reflected on the outcomes. And Niti is, at this point in time, trying to focus the attention of the states and of the district hospitals to ensure that better value for money is delivered to its citizens, which they deserve. Thank you.
Thank you so much, Alok ji, for giving your perspective and making it more rounded in terms of interventions. I have a kind of a situation where my personal clock has stopped at 5 to 12, not realizing it was 12:15. So it's an unintended Murphy's Law that has happened in. We had still 2 speakers to speak about the CSO perspective, but Srinath ji, may I request you as chairperson, if we all move up on stage and we could give them their perspective through conversations which you could steer. So that aspect would be covered, and we can then try to take a few questions and wind the whole thing up in 15 minutes. I know there are going to be people who are going to be upset with me. I take the brickbats with whatever that goes with it. Please bear with us, but let's come up on stage, and we'll have to give a certain amount of time to Ashok ji and Nitin ji to give their perspective, sir.
Well, since it is approaching lunchtime, let me give you a lunchtime analogy. Quite often in a very rich buffet, you find so many items, but you know that you cannot sample every one of them. And unfortunately, with such distinguished speakers, it's not been possible always to accommodate all of them because of some of the rushes that have happened in terms of the times. Now, it's also true that in the health system, in planning as well as in performance, in implementation, it is the community that gets neglected most. The academics, the government, the civil society activists all have their say, but it's the community that matters, but ultimately it remains a bit invisible. So I think the people who are supposed to speak on behalf of community have every right to feel a little agitated. But nevertheless, it is always useful in this interactive format to get the best out of their views rather than in formal presentations. So may I open up now with Nitin. Nitin, you have heard all the presentations, and you know that the community perspective is a very critical element in deciding what the priorities of the health system should be, assessing how well it is functioning, and actually participating also in everything from policy shaping to assessment and implementation and monitoring. How well do you think is the community actually engaging in this process? What are the barriers and how can they be overcome?
Yeah, thank you for inviting me. Actually, I am associated with an organization called Sathi, and we are working with around 50 civil society organization in Maharashtra, and where I think in health there are two approaches: service-based approach and right-based approach. I think right-based approach, service-based approach, everybody knows, providing the camp and mobile medical units and all. But right-based approach and where the community can be engaged, where civil society also has the major role, we believe that the government should take a primary responsibility to provide health services. And in that, community can give a regular and continuous and systematic feedback because they are beneficiary. And in India, unfortunately, there is no as such forum where you can get a feedback from community to the health providers, to the policy makers. And we try to develop that mechanism in Maharashtra through National Health Mission. It is called community-based monitoring and planning. We believe that inputs from the investment or infrastructure from the government, that can be fed or that can be viewed or that can be feedback by the community itself. And the community can take a responsibility of monitoring and also planning, decentralized planning in the context of utilization of the various funds. For example, in India, there is a Rogi Kalyan Samiti funds. These funds can be utilized with the pro people because there is a very vast spectrum. The order has been made that in all Maharashtra, in all one district called Nandurbar, there should be, through this RKS fund, AC means air condition can be allocated. These kind of malpractices are going on and these can be monitored to the community. And I think we have to engage community. We say that they are beneficiaries. They cannot understand the monitoring and all that. So we have developed a report card of each institution in the Maharashtra, more than 14 districts, and we have showed that these monitoring, community-based monitoring, can change the delivery of health services. And second important point is how you can control the big monster called private health sector. It is a monster because lots of players are involved in a private health sector and it is a not market. It should not be a commodity. It should be the service. And in that context, community can control the private health sector also. And we try to develop, I'm not talking about in the form of agitation, but we have tried to form a doctor-patient forum, where in the context of, in Maharashtra, there are lots of violence going on against doctor. And in that context, if you can't build a bridge between patient and doctor, then that bridge will lead to a mess. And in that context, there is a profit logic and social logic. I'm very concerned about the private health sector engagement, because private health sector means profit. It's a very clear-cut relationship. I will finish. So, in that context, we are talking about the universal healthcare, universal access to healthcare. Then there should be the strengthening the public health system. We should work for social control on private health sector. And I think there should be some kind of accountability on monitoring mechanism, where community can centrally involve in controlling the private health sector also and the public health sector also. Thank you.
Thank you very much for that clear but compressed message. Ashok, may we have a sharp but short comment from you on the same issues? Or anything else that you want to react to the presentation?
I was asked to speak on the civil society organizations and their role in the healthcare sector, so I'll stick to that. Before I start talking about the role of civil society organizations, I think it's absolutely essential, it's imperative today to define what we mean by what CSOs or NGOs in this country stand for. Over the last few months, all of you must have read in the newspapers, the legislature is after CSOs, the judiciary is after CSOs, the Supreme Court is after CSOs to cut them down to size. And we've been reading in the newspapers that there are lakhs of NGOs and CSOs in this country, and they are totally unregulated. Somebody has to regulate what they are doing in the country. So just before coming to this, I thought let's find out what the ground reality is. And so out of 36 districts in Maharashtra, we visited one district, found out with the charity commissioner, there are 30,000 NGOs or CSOs registered with the charity commissioner, out of which only 10 are providing services, social welfare services, the way we know that they should be provided. The remaining 10 out of 30,000, the remaining are religious trusts, they are schools, springing in all kinds of people are establishing schools, trusts to start schools, but as a commercial venture. And the largest number of NGOs or CSOs have been registered by politicians. So I will stop out there in terms of what NGO sector is, what it stands for, and we really do need a different definition for those NGOs who have been spending decades of their life providing services, either educational or health services in this country. That said, I will get on to what the role of the NGO sector has been. Starting from the independence onwards, if you look at the health policies, Dr. Reddy talked about health, the NGO sector or the CSO sector, providing the direction for policies in this country. If you look at the policy canvas, starting from primary health care, TBA training for maternal and neonatal health, to RCH, to the first national policy on IEC BCC, to ARSH, adolescent health care, every single major national health policy was originally innovated and initiated in the CSO or the NGO sector. That is when this innovation was taken up and scaled up at the state or the national level, and it became national health policy. I think the place where we are lacking, the gap is not in innovation. The gap is in recognizing the innovation and scaling it up. There is no mechanism in this country which will go and actually look at these innovations and see whether there is a potential for scalability and then take them up to the national or to the state level. The second thing that I would really like to, last point I would like to make is we talk of the NGO sector and the key primary role is innovation. I will quote unquote use one word to describe what the role of the NGO sector is. It's innovate. It's come up with strategies and systems which are different, which are more efficacious, and which have a greater coverage. And therefore, just by means of coverage, if the intervention has a higher coverage and it's at a lower cost, it's more efficacious, then that is the thing that is worth really scaling up in the rest of the country. There is where the lack is of identifying these innovations and taking them up to scale. Thank you, sir.
Okay, one question now permitted from the audience by the organizers. Fastest finger first. Please ask your question quickly. We are in the slog overs. They'll bat like T20 Pune team. Okay, go ahead.
Hello.
We have been divided. I wanted actually thank you very much for very good speakers. The question is, my question is very. I wanted to ask this question early morning.
No, quick question.
You are having have and have not. The have nots has to be given the services, but you I am requesting you to take this point very. I wanted to tell you that the have-nots have a
Is that a
very the number of family size is very big, and the haves have a very limited family size. I wanted to just focus on this line, one line.
Okay. Geeta, I think maybe you want to take it up, but very brief answer.
Well, the relationship between family size and a whole range of variables is complex, okay? So it's not only haves and have-nots, it has to do with the correlation with education, with mother's education, with the availability of contraceptive and family planning services. And most important of all, the thing to remember in this country, the rate of growth of population, if you decompose it into different components, the overwhelming bulk of it is coming not from high desired fertility. That is, it's not because families want to have large numbers of children, so much as it is coming almost 70% over this next 85 years of the rest of the century will come from what is called population momentum. And that is very like what is physics momentum, because we have a large young population base. And unless you tell those young couples they can have no children at all, in which case you can cut the rate of population growth. But you can't do it. It's not because very poor families are having lots and lots of children. That has changed. That picture changed long ago.
Unfortunately, we have been told that there is no scope for any further questions. Please do engage in the discussion over lunch or wherever you can have an opportunity. I think we'll give an opportunity to Jyoti to thank the speakers and the panelists on behalf of the organizers, and then call this session to an end. Obviously, it's been very stimulating, but clearly the discussion will continue to go on as it should.
My humble apologies for the delay, and without further ado, a big thank you to all of you for being here and for sharing your views, and an even bigger apology to my panelists who have not been able to share their thoughts to the manner in which they should have been able to. I think I probably failed as an anchor. Please forgive me for that. Thank you.
Thank you so much, all the panelists and our very own anchor, Professor Jyoti Chandiramani. I request all the panelists to please stay back for felicitation. May I now request Dr. Rajiv Yervadekar, Dean, Faculty of Health and Biomedical Sciences, Symbiosis International University, to kindly felicitate our speakers. Photographs are being clicked and memories are captured. Thank you, Professor Jyoti Chandiramani, for your commitment towards our session. I request all the delegates to please remain seated in the convention hall. We have video conferencing facility available. On the screen, we'll be showcasing CSR activity that is going in the auditorium, main auditorium. So you all are requested to please be seated here only.